Okay, next up we have Dr. Francella. So Alex has been a phenomenal collaborator over the years. Has been helping organize this conference for the last couple of years. He works at Cleveland Clinic Canada, University of Toronto. He's spent coverage included working with Soccer Canada, Basketball Canada, as well as the Toronto Football Club. And he's going to be giving us a talk on spondylolysis and spondylolisthesis. So, warm welcome for Dr. Francella.
Let's get started. Okay. So good morning, everyone. As Neil said, I'm Alex Francella, sports medicine doctor here in Toronto, and today I'm going to be talking to you about spondylolysis in the young athlete. I decided to do this topic because I've noticed a significant increase in the number of cases of low back pain in the adolescent population over the last couple of years. So it really piqued my interest to do a bit of a deep dive into the topic and review some of the associated literature. So I'm hopeful that the talk today will be able to reinforce some of your knowledge and also bring to light some new information to guide your clinical practice. So again, no financial disclosures to make. So we'll just briefly review the goals and objectives of this morning's talk. So first we'll define spondylolysis and spinal anatomy. We'll understand the pathophysiology, risk factors, and biomechanical properties of the condition. Then we'll discuss the diagnosis, treatment, and return to play strategies. And finally, we'll go over a bit of a real-life case. So first, we'll take a quick look at some basic spinal anatomy. So an example of how Dr. Richards has influenced my career is that whenever he would counsel patients on back pain, he always said there are 33 bones in the spine, and at different levels there are 3, 5, or 7 joints at each motion segment, and so you have 100 joints and over 150 fascicles and muscles in the trunk alone. So obviously this makes diagnosing the cause of back pain extremely challenging, as many of us experience in our day-to-day practice. However, for the sake of this talk, we're going to be looking at a structural injury, so we have to look specifically at the pars interarticularis, and this is the bony bridge that connects the superior facet and the inferior facets of the vertebrae. So spondylolysis is a term broadly used to describe defects in the pars interarticularis. The Wilt classification divides it into 5 categories: the isthmic category, dysplastic, degenerative, traumatic, and pathologic. The most common type is the isthmic form, and this is a unilateral or bilateral bone stress injury to the pars interarticularis. And for the sake of this talk, this is exclusively what we'll be referring to. So nowadays, spondylolysis is generally considered to be a result of repetitive mechanical stress and microtrauma to a congenitally weak portion of the vertebrae. So similarly, the higher incidence of spondylolysis in young athletes is thought to be related to increased overload in the lumbar spine. And we're going to examine both of these concepts in further detail. So spondylolysis and spondylolisthesis is my favorite tongue twister in medicine. And so these injuries, like other bone stress injuries, occur on a continuum, with spondylolysis representing edema that may progress to a defect in the pars interarticularis, and spondylolisthesis represents the defect and then subsequent translation of the vertebrae. And spondylolisthesis itself is usually when the superior vertebrae is most commonly going to translate anteriorly, but can also translate posteriorly. The Meyer-Ding classification breaks it down into 4 different grades, which each grade representing an increasing percentage of translation, which you can see there on the bottom photo. So looking at some of the epidemiology, low back pain in general is very common chief complaint in the pediatric athlete. Up to 50% of athletes report some level of back pain, with that number steadily increasing over the last decade. Interestingly, just to play off our last speaker, there is an unclear role of sports specialization in this increase. It's been reported that up to 6% of the general pediatric and adolescent population will experience spondylolysis, and then unsurprisingly, that's going to be higher in those participating in competitive sports. The vast majority of the cases are going to occur at the L5 lumbar segment, and spondylolysis is most common in such sports like gymnastics, rhythmic gymnastics, football, wrestling, weightlifting, and basically that entire list that Dr. Person showed up earlier. Interestingly, it has been shown that some adolescents may actually be prone to this injury during the off season when they're going to be engaging in more repetitive movements while doing certain strength training exercises a little bit more routinely than they would when they're in their in-season schedule. So now that we kind of understand the who and the what, now we'll take a look at the why and the how of spondylolysis. So the etiology of it is mostly unknown, but there are two recognized theories, and they are mechanical, biomechanical, and the genetic. So as we've discussed, it's a bone stress injury, so similar to medial stress syndrome. Repetitive movements with inadequate rest leads to micro damage and edema of the bone, resulting in an inflammatory and osseous healing response. So it's typically, when I'm talking to my patients about this injury, I'll describe it as shin splints of the back. Mechanically, PARS itself is actually susceptible to chronic axial loading due to the high stresses it experiences during extension of the lumbar spine. When we look at the actual anatomy of the spine itself, the pediatric spine has some areas that put it at specific risk. And the first one of this is the strength of the neural arch actually continues to increase until the age of 50. So this is obviously a point of weakness in the pediatric spine, which then increases the subsequent load on the PARS. And secondly, the intervertebral disc itself is much more elastic in the younger population, again, causing there to be increased stress based on the PARS. So another risk factor is growth spurts, again, which was mentioned in the last presentation. So peak growth velocity tends to occur around 13 and a half years of age. And so this then results in the bones growing faster than the muscles. And this delay thus requires a greater muscular force to generate the same amount of acceleration. So for example, the muscles of the lower legs actually need to produce about 30% more force after the growth spurt to generate the same amount of acceleration. So this then leads to greater forces being exerted on the bones, and thus the adolescent athlete has an increased susceptibility to these bone stress injuries during the period after the growth spurt. So this sort of lines up with the age of 15 being the most common age of presentation for spondylolysis. Finally, when we look at the other but less commonly seen but also equally important etiology of spondylolysis is the genetic component, and studies have actually demonstrated an increased incidence in first-degree relatives. So you want to make sure that you do a good family history when you're seeing these patients. And other congenital conditions such as spina bifida occulta and scoliosis have been associated with spondylolysis. All right. So some of the risk factors, obviously, as we know, athletes are going to be at a higher risk than non-athletes in these situations. Females are at a higher risk than males, and athletes who repeatedly move through lumbar hyperextension and axial rotation, and then those that are participating in high-risk sports. I actually found a study that was published back in 1989, so a long time ago, and showed that Canadian Aboriginal patients were actually at a higher risk of spondylolisthesis, which I found quite interesting. And then again, regardless, you want to make sure that you're considering this in all athletes that present with low back pain, because up to 47% of athletes between the ages of 12 to 18 years old who present with atraumatic low back pain will have spondylolysis. Okay, so we got some background knowledge about the condition. Now we're going to step into the clinic and review how these patients present and then how we'll diagnose them. So the mean age is 15 years of age on presentation. They're usually going to present with an atraumatic gradual onset of their pain in relation to an increased amount, frequency, or intensity of activity. However, it is possible to have an acute onset as a result of a single overload event in the background of low-level pain. So whenever somebody presents with an acute traumatic injury, especially an adolescent athlete, you always want to go a little bit further and say, okay, do you have any of this kind of pain, even at a lower level prior to this acute event? The symptoms are usually going to be localized to the lumbar spine, either unilateral or bilateral. They are typically worse with activity and follow the bone stress type of pattern where the symptoms worsen as activity progresses and don't warm up as a tendon or muscle injury would. And then more specifically, lumbar extension with or without rotation would aggravate these symptoms and will be improved with rest and avoiding those aggravating positions. There may be some radiation to the buttocks or the upper thigh. However, there should be an absence of neurological symptoms such as radicular pain or paresthesias. Constitutional symptoms and cauda symptoms should also not be present. And if any of these are, then you want to make sure that you're considering other potential etiologies before agreeing on this diagnosis. So as Dr. Pearson said, the activity history is an extremely important part of this encounter, and you want to be able to determine the frequency and duration of their activity across all activities. So that includes practices, games, and any of the training sessions that they're participating in. Additionally, you want to get a sense of their handedness in their sport, which may lead them to favor one side over the other, and any sport-specific techniques that may be relevant to the injury. Also, you want to ask broadly about any other physical activity because most of these athletes are very busy individuals, and so they're going to be doing multiple sports, they're going to the gym, they're in a gym class, or they're participating in some other non-organized physical activity. Also, depending on the clinical context, you want to do a bit of a screen or perhaps even a more in-depth REDS evaluation, looking at their menstrual history, any history of previous bone stress injuries, looking at what their diet is, and any other potential signs of an underlying eating disorder. And then finally, you want to complete it by doing a family history, looking for any presence of spondylolytic defects or other autoimmune conditions. So moving on to the physical exam, like all physical exams, you want to make sure that you're being thorough and systematic in your approach to avoid missing any other potential causes of back pain. So for this, we're just going to be looking at the positive and negatives to make you assess things. So first, looking at inspection, you want to make sure you're looking for any skin discoloration, dimples, patches, or tufts that may indicate previous spina bifida occulta. On palpation, they're probably going to have some tenderness along the spinous process or just lateral to that area. And then sometimes their paraspinal muscles may be tender if they're in spasm. Here, you also want to make sure that you're palpating the SI joints, which can be a pain generator in extension for both back pain. And in this population, you may want you to consider potentially an autoimmune spondyloarthropathy. On range of motion, they're going to have pain and usually reduced range of motion in extension. And you may need to complete multiple repetitive movements to elicit their symptoms. And pain with extension is 81% sensitive for spondylolysis. Also, a little bit of a pearl is you want to make sure that you're documenting what the degree at which they're having pain. And this can help you to monitor progress in follow-up assessments. Of course, you're going to do a complete neurological examination as well. Typically, it's going to be normal, but if there is any weakness or any decreased sensation on a myotome or dermatome, you're going to want to think of a potential anterior or an alternative diagnosis. So the one main special test that is indicated here is the one-legged hyperextension test or the stork test, where the patient stands on one leg and they're passively moved into hyperextension. Fortunately, like most of our special tests, there is a low sensitivity and a specificity associated with this. So, as we know, our history and physical exam is mostly going to guide what our next steps are, and usually we're going to be able to make this diagnosis clinically without any imaging. However, we know in this day and age when patients think that or parents think that the patient is the next phenom, they're coming in usually expecting some type of imaging. And so given this, we really need to be aware that there is actually no consensus imaging algorithm or even an agreed upon first-line treatment. And so we need to understand the utility and limitations of each of these modalities in order to make an informed decision. So X-ray, of course, is the most readily available test. This includes the AP and lateral views. You can do this without flexion or extension views. The oblique views have fallen out of favor as we've realized that they do not add any diagnostic accuracy, and we're just exposing the patient to increased radiation. Unfortunately, that classic Scotty dog deformity that we all learned is seen on those oblique views. And although it's a good initial screen, we know that X-rays are specific and not sensitive when it comes to stress fractures, especially when they are in their early stages, with a false negative rate exceeding 50% when compared with MRI. So just looking at some x-rays here, you can see the classic spotty dog deformity with the collar being represented representing the fracture on the dog. So CT is the gold standard for imaging spondylolysis, as it's best at delineating the anatomic lesions. It's more accurate than X-ray and better than MRIs for directly visualizing pars defects. It's also ideal for assessing healing and evidence of sclerosis or bony bridging. The CT of the lumbar spine is not sensitive for detecting early acute stress reactions in the pars when maybe there's only some marrow edema or microtrabecular fractures. And the biggest hesitation is in the CT is the radiation exposure, but it has been shown that decreased or low dose CT scan can be used with similar accuracy. And so this is the preferred method in the adolescent population. So I'm actually really interested when Dr. Steinbeck is here later in the day to discuss this with her and how we can better serve our patients when deciding what kind of imaging we should be ordering. So looking at some CT scans, we can see these axial and sagittal cuts on the top, very clearly showing pars defects, and then this bottom picture here showing some evidence of sclerosis. And just a little something interesting that I found is this Darth Vader sign. And this is was used to improve the detection rate of spondylolysis in abdo-pelvis CTs. And so they may be underreported if that CT is performed for another reason and may help to improve patient care. So it's a little bit more relevant for radiologists that are reading CT and abdo-pelvis either in the emergency department or in other settings. And so not super relevant for us, but I'm a bit of a Star Wars nerd, so that'd be fun to put in there. Okay. So moving on to the MRI. And so MRI is this advanced imaging modality of choice. It has a number of advantages. It's favorable side effect profile with a lack of radiation. It's very good at identifying early bone stress injuries and bony edema. It has a high negative predictive value. There's actually been the development of thin slice MRI protocols that are specifically designed for evaluation of the pars interarticularis, and this has led to improved performance with a sensitivity approaching 92 to 98%. Some of the limitations is that there may be a motion artifact in the young athlete. However, I find this is a little bit less likely in my practice, and most of the athletes that I'm ordering MRIs are able to tolerate lying still. And then you have a false negative rate of about 41% versus 23% in the CT scan. So this is the study that looked at the thin slice MRI protocol. And so this is from Japan, a group in Japan, and they had the pars interarticularis fractures evaluated on what's called a T1 weighted volumetric interpolated breath hold examination, or a T1 vibe. And this is in addition to the CT scans, and their aims were to validate the consistency between MRI and CT scans. So what they did is they looked at 105 patients below the age of 18, and they were diagnosed with spondylolysis, and they underwent both a CT and MRI less than 2 weeks apart. When you look at the data, it was actually just a couple of days. And in total, they evaluated about 190 fractures. So as you can see, when you compare the CT on the top and the T1 vibe on the bottom through various stages of spondylolysis, so A is bone resorption, B is a hairline fracture, C a complete fracture, and then D is the gap. The pictures actually look very, very similar. And so when we delve into the numbers, there's not a lot of discrepancies between what the MRI showed and the CT showed. The main discrepancy is that when 124 CT showed incomplete fracture, of those, 5 MRIs actually reported it being normal. So overall, the T1 vibe sequence showed sensitivity greater than 97%. And so they show that it's a highly accurate modality or protocol that can be used in conjunction with the STIR sequence. And they hope to adopt this to further reduce radiation exposure in the pediatric athlete. And so my main takeaway was that you could say the study showed that the MRI can pass the vibe check of diagnosing pars fractures. So as we move on, MRIs are also accurate in helping us develop an accurate prognosis. So when there's cortical edema, or what's known as a high signal change in the pedicle adjacent to the pars, this is actually a positive predictor of bone healing compared to when it's not, and we'll look at some of the specific numbers a little bit later on. Additionally, MRIs are going to be your imaging tool when there's some diagnostic uncertainty, and it's going to help you to detect any other concurrent pathology. So again, just looking at the MRIs here, you can see that there's a high signal positive on the top, a high signal negative. Excuse me, and then you can see a CT scan that looks relatively normal, but on the T2 stir, you can see some of the there at the bottom. Okay. Excuse me. So now that we come to our diagnosis, we'll do some treatment and management options. So the goals of management are to promote healing, diminish pain, and prevent progression. Excuse me. In addition, there's going to be, when this is initiated, you're usually going to have some activity modification. You're going to avoid all your aggravating movements for about 6 weeks. And this may require either a complete cessation of all activity or a discussion about what modifications could be made. I think this is really the most important part of your management. You really need to get buy-in from both the patient and the parents in this area, and it may lead to an open conversation because they may be resistant and say, well, what do you mean I have to stop everything that I need to do? And so there's a little bit of a push and pull here and trying to find a happy medium that allows recovery to take place. So there are some positive predictors of recovery, and this is when the defect is unilateral, it's early on, or in the lumbar stage, other than L5. So pharmacotherapy, not essential, but it can be helpful. So you're going to use some basic pain control. You could use corticosteroid injections to pars or to the facet joint in some refractory cases, and there have been some case reports of actually using radiofrequency ablation in these patients. Teriparatide, which is a PTH analog, has been used or shown to be used in professional athletes, mostly due to their faster recovery of osteoporotic fractures and some increased bone union in spine fusion surgery, but there hasn't been any specific studies in its use in spondylolysis. And then I typically recommend vitamin D in all these cases. All right, let's see how much longer my voice is going to last. So, physiotherapy, its goal is to improve neuromuscular control, targeting imbalances in the transverse abdominis and the multifidus. This is going to help to sort of promote improvement in segmental lumbar flexibility and stability. Physio has also been shown to lower the rate of refracture, and they're going to basically engage in physio for the duration of the recovery, which can be anywhere from 2 to 4 months or potentially longer. Physiotherapy was actually delayed previously until the patient was asymptomatic, but it showed that this led to further issues related to too much rest, and that the immediate and early introduction of physio allowed return to sport up to 2 months faster without any increase of adverse events. So we'll discuss a bit of a controversial topic in spondylolysis, which is bracing. So the overall evidence here is mixed, with the positive results of bracing likely due to a product of the activity restriction that the bracing enforces rather than the brace itself. But I actually went to the Boston Overlap manual, and it discusses a variety of other potential factors that could lead to improvement in the pain, and these are things like contra-abdominal pressure, attainment of an anti-lordotic posture of the spine, and also spinal distraction. So usually you're going to use bracing in combination with other forms of management, and there's a number of different options. There's the TLSO, the LSO, the BOB, and other sort of non-rigid braces. And the duration of use is extremely variable, anywhere from 1 to 16 months. And so looking at the sort of landmark study that led to the BOB being introduced in 2002, they showed that when it was used in combination with physiotherapy, there was an 80% return to sport in 4 to 6 weeks. If they continued to wear the brace and they remained pain-free, 94% had fractured union at 3.2 months. But when they actually looked at patients all the way out at a successful return to sport at 1 year, the rates were 89% with the brace and 86% without the brace. So their conclusion was that the bracing actually didn't really affect the clinical outcome at all. And so the major benefit, as we talked about, is the activity restriction rather than the brace itself. And its indication is usually non-compliance with activity restrictions, which is usually when I'm going to be trying to implement that in my own practice. And then if they do need a timely return to sport, when you talk about that initial study, they had an 80% return to sport in the first 6 weeks. So if it's a high level athlete and need to get back quickly, then it may be something that you consider. So this is what the braces look like. Usually in my practice, I'm using an LSO. I'd be interested to hear what other of you are using. Mostly just due to ease accessibility. It's a little bit more discreet and less cumbersome, which I think will lead to better compliance overall. So when we look at some adjunctive therapy, the use of low intensity pulse ultrasound or a bone stimulator has good potential for increasing bone union rates, but we actually had a talk with Bioventus a couple weeks ago, and it's still an off-label use of the stimulator. And so one of the studies showed increased bone union from 10 to 67% compared to those with use in conventional treatment. And then Sukata and his team looked at 80 athletes in early stage of spondylolysis, and they showed a reduced return to sport time by 72%. So 61 versus 167 days is pretty good. But of course, like most things, you need to have larger studies to see whether or not this is a key component to our conservative management. And finally, 5% of athletes, unfortunately, are going to progress to surgery. And these are going to be patients that have debilitating pain for more than 6 to 12 months, if they have any evidence of neurodeficits, or if they're worsening symptoms overall. And typically they're going to do a little bit better when it's a unilateral defect at a younger age, and they're either going to undergo direct repair or a fusion. Okay, now how do we return these patients safely to their sport? So again, like most things in sports medicine, there is no optimal treatment algorithm due to lack of consensus and large-scale controlled clinical trials. So the largest meta-analysis that I could find was about 430 patients, and the average return to sport was about 4.5 months, with a large portion of them returning to their pre-injury level of pain. So the ones that do, the criteria that do exist are usually image, time, or symptom-based. So image-based, has its own problems, as we know. The bone healing bone healing that we see on imaging lags behind what we see clinically and is not always associated with a successful return to play. However, where it can be helpful is the prognosis. So if you remember when I talked about the high signal change that we see on MRI, when the high signal change is seen, the 3-month healing rate is 64% compared to 27% when there is not that signal change. So again, overall, using the symptom image-based criteria is not routinely recommended. Time-based guidelines is extremely variable, and then symptom-based guidelines is when the athlete is pain-free on physical exam and with all their activity prior. So in clinical practice, you're going to be using mostly a combination of time-based and symptom-based, and it usually follows this trajectory of a defined period of rest, the athlete achieving either both pain-free at rest and with activity, and in your clinical assessment, having them initiate a gradual return to activity, and either an immediate cessation or reduction in activity, depending on whether their pain returns. So the largest study that I could find looking on the management is this retrospective study looking at about 200 athletes between the ages of 10 to 19. And this was over a 12-year period. They were evaluated at a single institution, and the diagnosis was made with X-ray followed by MRI and then CT scan. And so the same procedure for the diagnosis and then conservative treatment was used for each patient. There wasn't a control group. And so their management plan was the cessation of all sport. They were put in that big honky TLSO brace for 23 hours a day for 3 months, and then also prescribed a bone stimulator. At 3 months, they had that brace removed, they had a CT scan, and then engaged in a 6-week physiotherapy program. After that, they were then assessed again. If they were improving, they kept going with their recovery. If they were continuing to be symptomatic and they had edema on their MRI, then they had a corticosteroid injection. And the study had a 98% return to sport, with one having to undergo surgery. So again, did the brace actually help, or was it just the 3 months of not doing anything that really helped their healing rate? Again, it was actually interesting that even though they had this big component of bracing, they didn't evaluate the compliance with the brace at all. And so that was an interesting part of the study. And additionally, they used the bone stimulator. It did show an increase in healing rate on imaging, but we know that that doesn't always correlate. And then they did recognize that the algorithm is extremely costly, and that you could basically do this without an MRI, bone stimulator, or a CT scan and really achieve similar outcomes. So finally, we'll just finish up here with a bit of a real life case study. So this is a 16-year-old female, right-hand dominant, high-level hockey player who at the age of 16 already has her free ride to a D1 school coming in. So she presented with a 3-month history of intermittent low back pain that was exacerbated when she fell hard into the boards and developed some worsening pain and had some seizing on the right side. On further history, she described some low-level aching pain for a few months and an episode of low back pain about a year ago. On exam, her pain was worse with extension and then extension and rotation. She had no cauda equina, no red flags, no cauda equina symptoms. She had 3 total menstrual periods since achieving menarche at the 10 months prior, and didn't have any restrictive or disordered eating habits. So as you can see on her activity history, she's extremely active, mostly with hockey, but she does do some field hockey in the fall and some track and field, but most of these also will put her back into hyperextension. So prior to seeing me, she had an x-ray a year prior, which was normal. About a month or 2 weeks prior to seeing me, she had an x-ray done in the community, which showed a spondylolytic defect and some anterior lesis, and then another one done at Sick Kids, which said the same thing. When I examined her, she was very reduced in her range of motion in all directions, with pain being exerted at only about 10 degrees of extension, and she did have some tenderness palpation of her SI joint. So with that, we made the clinical diagnosis of a spondylolysis, advised no back bending, no skating, no high impact activity, started her on some physiotherapy and some vitamin D supplementation, and thankfully she already had an MRI that was pending. So when I saw her 1 month after, her MRI report showed some early degenerative changes at L4-5, L5S1. She was seen by another physician and told based on this that she had mechanical low back pain, that she could just go back to her activity as tolerated. Fortunately, with that SI joint pain and the sacroiliitis that was seen on x-ray, she had some inflammatory blood work done that was normal. When I saw her, exam was completely the same. A lot of pain, and I was like, this doesn't seem right. So I took a look at the images myself, and I thought that I could see some edema in the pars, so I sent it off for a second opinion consultation, which showed these bilateral pars defects in the L4 region. And so with that, again, we sort of took this time and symptom-based approach. I saw her probably every 4 to 6 weeks. She was very diligent with what she did. At one point, I even had a call with her chiropractor to determine how she could best do things. She, had some mental struggles with not being with her team. So I said, okay, yeah, you can skate as long as there isn't pain, just to have her involved. And, thankfully, she was able to get back to full sport within about 6 months. So, in conclusion, spondylolysis is a prevalent condition among the adolescent athlete. Early diagnosis and intervention are critical to ensuring better outcomes and minimizing the long-term complications. Effective management begins with taking a detailed history to identify the key risk factors and symptoms, and from there you want to implement a multidisciplinary approach. We've talked about the time and symptom-based return to play framework. And then, again, prevention remains the most effective long-term strategy. We want to emphasize education, training modifications, and symptom monitoring. So looking ahead, what are some of the roles for bone stimulators in recovery, I think is an important part, what the best treatment algorithm is, and then over discussion with this topic with a lot of my colleagues over the last few months, we sort of talked about are we overdiagnosing spondylolysis in these athletes, and how do we differentiate it between pattern 2 low back pain and SI joint related pain. And so interestingly, this MRI report, I don't know if you guys can read it from there, but this is an MRI of a 15-year-old rhythm gymnast that I saw, and she had extension-based back pain, and I was convinced that she was going to have a spondy, and so we ended up getting an MRI a little bit sooner than I would have because she had a major competition coming up, and so this showed that she already has multi-level mild facet joint arthrosis at 15 years old, so just something to keep in mind moving forward. So thanks again for the opportunity, and happy to take any questions.
Thanks so much. Anyways, I'm a pediatric emergency doctor, and I get a lot of back pain in high-level elite athletes coming to the emergency department. A couple of questions around that. Families are super interested in injections, and I don't know anyone doing pediatric back injections or if they would be recommended, but they're taking it from the adult kind of sports med, sphere and bringing it into their kids' world. So I'm curious your thoughts on that. And secondly, I'll often recommend rest if I'm concerned about this and kind of limiting sports. What's the threshold to send to sports medicine? Because again, we're having referral problems with these younger kids. A lot of sports medicine doctors say they don't see pediatrics. So I'm just curious your thoughts on those two things.
Yeah, so I would say in terms of injections, almost never. I've never sent anybody for injections. I think that it's going to be a very refractory case that isn't getting better over a long period of time, bordering on 6 to 12 months, I would say for sure. Like I said, in my practice, I've never had to refer anybody for that, so definitely not in the emergency department. I wouldn't be recommending that. And in terms of when you're seeing somebody in that acute care setting, I think it's very appropriate to just recommend rest right away. Depending where you're practicing, I think there's a large portion of us in this room that do see pediatrics, so we're happy to chat and maybe get a referral pattern for you, and we'd be happy to see them, provide them with the appropriate care that they need, because I know when you're in the emergency department, it is really challenging to provide good care, good recommendations, good counseling around this. So I think just the initial management of basically avoiding aggravating activities, don't do any lumbar extension until you're pain-free, and then following up with sports medicine for further management.
That's great, thank you.
No problem.
I'd add to that. Some for physio early out of the leg. Yeah, and make sure they go. Yeah. We tell the family that's important.
I try to make it seem like treatment. They really
well, even just by saying it, you don't have to wait to see the sports doctor to see the physiotherapist.
Yeah, so I usually write a book for them, just so they make it seems legitimate, but it's just so, I feel like I'm crawling up this hill of people wanting intervention, and it's really upsetting, so.
Just on the topic of injections,
Yeah.
in almost 16 years, I have yet to send a patient for an injection, and all I see is kids and teenagers.
Yeah.
As a sports doctor. So, if you're thinking injection, think about why, and this may not be the right specialty, and then you need to see room or something else may be going on, so.
Yeah.
Alex, thank you for your talk. The question I have is with regards to the oblique films of the lumbar spine. You say that we don't need them anymore, yet is that from the radiologist's diagnosis of the radiographs and their interpretation, or is it from most of us who don't see lumbar spine x-rays on a day-to-day basis, i.e. emergency physicians or your family physicians and beyond?
Yeah. So I think what they've shown is that they're actually able to see enough on the APs and the laterals to come to say whether or not there's a defect or not, and so they don't really need the oblique views to further their diagnostic accuracy.
But who is it?
I'd have to go back. I can't remember specifically.
Because again, in the emergency department, you know, you're trying to get the things done quickly.
Yeah.
And if you want to take those oblique films, I think they give you a better picture of that, and you can come up with a better diagnosis right away for the families who really want to have that diagnosis, rather than waiting for the reports to come back from the radiologist.
Right. I mean, I think it's important to recognize that even though you're not seeing, even if you're getting an oblique, so you have to get a risk reward, right? So if you have enough on your clinical examination that's saying, yeah, I think you have a spondylolysis or a stress fracture, then even if you have a normal or negative X-ray, you're still going to be recommending the same thing, right? Because the X-ray is going to be, it's going to be specific, but it's not going to be sensitive enough. So again, is that oblique film really going to change what your recommendation are? I understand that the patient's going to want a diagnosis, but it's that same sort of thing of it's up to us to be confident in our clinical examination and say, do I really need to expose this patient to an oblique film if it's not going to change sort of what my measurement plan is?
Next question. The STIR technique or the STIR sequence, what, can you explain that a little more fully, please?
I would defer to a radiologist or something like that.
Yeah, we're actually going to have Dr. Steinbeck in later, so we can get her to go into the details of the MRI. Just specifically that's two specific emergency related questions. So the first thing is if you're having an athlete come into you and they're having pain with extension, first thing is categorizing as extension related back pain. And the first thing you should be talking about, this is part and parcel of Dr. Person's talk, is this is the problem with sport culture, is if you're having that much pain that you're coming into the emergency department, we really should be talking about an injection. We should be talking about your recovery period. And this is the importance. If we're playing sports as kids, part of sports is getting injuries and how do we manage that? The other thing is low threshold for referring to your primary sports medicine colleagues. We'll put together a list for you guys afterwards, but most of our colleagues see kids, and we can put a list together throughout the city for you guys to have at sick kids that you can refer to as needed.
That would be great. And also how you'll see.
Oh, 100%, yeah. I'll do a survey in the WhatsApp group.
That would be perfect. Thank you. Yeah, specifically to you would be great.
So great talk, very great time. Just a couple questions. I was going to ask about the STIR imaging too, so I'll be keen to hear that next time. Number one question, any difference between like T1 versus T3 MRI sensitivities? Next question is going to be, sometimes with chronic like NSAID use, it's been shown to delay kind of bone healing a little bit. Did you come across any of that in terms of putting spondies on too much, AGO?
Yeah. So I would say first for the MRI, yeah, I would imagine that 3T is probably increased your accuracy. I didn't come across anything specifically comparing those two things, but obviously, like Dr. Ditworth said, I would look forward to Dr. Steinbeck's presentation later on. And then in terms of the NSAID use, yeah, I think that's kind of continuing to be a controversial thing in orthopedics. I believe the studies show that the NSAID use doesn't really prevent osseous healing. And so again, it's one of those things where if you're having a patient that's on chronic anti-inflammatory medications for pain, like you gotta start looking for other things that are causing it. And they shouldn't really be on any kind of regular anti-inflammatories. Usually I'll use it if they're in an acute flare and it's like 1 or 2 weeks at max, and that's about it. But I'm very rarely having these patients on chronic NSAIDs.
Thanks for the presentation. I just have a question also about the referrals. From the community basis, say for example, someone comes in with an extension type back pain, and for us from the family practice to refer to sports medicine, you want to have like the MRI in place before that, like, because of the low sensitivity of the X-ray, or are you okay to kind of like accept referrals based on clinical examination? Because I think that's the most difficult part for us, like getting the patient accepted from the community.
Yeah, I think that if you're concerned enough, then absolutely we can see without MRIs. We all understand the limitations of obtaining timely MRIs, and most of us would probably see without an X-ray as well. I mean, if you're clinically concerned enough that you want to make sure that there isn't an obvious fracture that would change your management, then by all means, I think getting an X-ray is very reasonable. But I think that we're definitely okay with seeing these referrals without MRIs. Absolutely.
Tonight, 16 a.m.
Hey, thanks for the great talk. 2 questions. If people do want to use bone stim, do you know, is there currently any suggested protocol, or is it just use until pain resolves?
Yeah, so there's no protocol. I think when we talk to the bone stimulator reps and whatnot, the biggest thing is kind of localizing it to where the actual fracture is. So one thing, if you are considering that, I think if they go for an MRI or even for an X-ray, if it is present on an X-ray, to have like a marker on the skin so that you know exactly where to do it. And then usually they're going to follow it until there's osseous healing on imaging. And I think it's like the protocol is 20 minutes a day for a prolonged period of time.
And where are you recommending people to get the LSO brace?
I think we just have it at our clinic.
Oh,
Yeah, I don't have any risks, nothing special.
thanks.
Ellen?
Couple points, way back in the day when Boston, one of the grandfathers of pediatric sport medicine, Lyle McKinley, was promoting the bracing. It was really about promoting healing in those young athletes, and so that became adopted, and there was some data. But at the end of the day, the whole question about imaging and how much intervention and the costs, I think you just personalize it to the athlete. And yes, we do know that there's a peak in adolescence, but sometimes these people don't present until their early 20s. Like the young hockey player who's has an opportunity to go semi-pro or pro, actually get paid for his passion. He's got a back that looks like he's 100 years old. So he was undiagnosed for all that length of time. One of the clinical things too, people say, well, I think it's just muscle spasm. So you get them prone on the bed and you put them into passive lumbar extension. Now that takes a bit of work, especially for me with my bad shoulder, but you can do that. And if you reproduce their pain and you know they're not activating the paraspinals, that's helping you confirm that clinical diagnosis, and then they realize, okay, yeah, that is different, and a little bit more likely to comply. But I think we just have to personalize it. The hard part here is the clinical diagnosis for most of the time, and people want the test. So you do your best to follow that, right?
And I think that's one of the main reasons why there are no consensus guidelines, because every patient is different. They're all going to present differently. They're going to have different challenges that they want and what they want to achieve. And so, yeah, I think it's really important to personalize things. And can't remember what the last part we were talking about. But yeah.
Excellent. Thank you very much, Alex.